Hello, today I would like to talk about tracheostomy in children in 2017. The reason that I want to talk about this because it becomes more increasingly performing trach in pediatric ICU. As you can see, the number is over 1,500 pediatric patients over the 2 year period from 2009 who got trach. And most of the time, we usually have a discussion about when should we perform trach in intubated kids. We have a number of 2 weeks as a cutoff point, but it's not a strong evidence-based medicine, and the number that we got it varies significantly from one unit to others, from 4 days to 30 days. However, in adult, they are moving forward to look at a cutoff point of only 72 hours of intubation to consider trach placement. In pediatrics, we have two different manufacturers. On the left picture, Chile, it made from PVC in contrast to on the two right side of pictures, we call Bivona, which made from silicone. Pediatric trach tubes differ from adult tubes in a number of ways. In kids, the tubes are single lumen regardless of manufacturer. There is no removable inner cannula, and we don't have fenestrated tubes available. Most of the time, manufacturer they have two different sizes between neonatal and pediatric sizes. Generally, children up to approximately 5 kilograms use the neonatal size. And the standard way to determine the adequate length is by performing a flexible scope through the tube to assess the lower tube position in relation to the carina. It is very important that the size of the trach tubes that is selected is appropriate for both the size of children's airway and the clinical indication for placement of the trach tube. In general, the smallest tube capable of giving adequate gas exchange should be chosen. A larger one may be required for ventilator-dependent patients. We want to prevent a significant air leak. That's why we choose the larger tube. However, an oversized tube may result in tracheal mucosa injury with ulceration and bleeding, and then subsequent fistulization or trach stenosis. A tube that is too long may migrate into the right main bronchus. We also have a formula to calculate an age-appropriate tracheostomy tube by using age in years divided by 4 and then plus 4 millimeter. It is equal internal diameter of ET tube. This can then be converted to appropriately sized tracheostomy tube as a table that in the next slide. This is a table to show you by Vona different tubes and size of tubes, and it also show cuffed and uncuffed tube. And the size, when we talk about size, it indicates internal diameter. And from here, you can see by Vona, I mean, most of them, they are not MRI compatible. In contrast, if you see trach from Chile trach, you can see all of those are MRI compatible, which means that if you got a patient who has a trach from Bivona and you plan to do MRI, you might need to change to switch from Bivona to Chile. And this picture, I will show you that about a custom trach for a specific patient population. I downloaded this template from the website, and you can choose. I mean, from the template, you can see that custom tube options is include connector. You can choose between swivel or fixed. Shaft style, you can choose standard silicone, hyperflex. You can mention about curvature that you want, even length, cuff design, cuff position, and neck flange. In my unit, we have a stock of Bivona Flex 10 tracheostomy tubes because we are used so frequently, and the Flex 10 tubes have a permanent flexible tube extension on the proximal side of the neck flange, which helps us to keep connections away from the neck, chin, and stoma, and also helps to prevent circuits from getting disconnected. I would say this tube type is commonly used in small infants with short and fat neck. We have two options to perform trach. The most popular one in pediatric world, it is on the left side of the picture. It is an open surgical tracheostomy, and we usually have two-stage suture and vertical incision. Compare on the right one is a percutaneous tracheostomy, which is becoming very popular in adult ICU. They said that it is safe procedure, it is easy, and it's bedside. This table, I would like to show you data regarding percutaneous tracheostomy studies in children, almost a 10-year period. It's also becoming popular, but you can take a risk of esophageal perforation from this table, and I think it would be safe to perform in adolescents. I would like to talk a bit about post-operative care in the ICU. This is from International collaboration from Pediatric ENT around the world, and it published in Journal of Pediatric Otorhinolaryngology in 2016. They split it into 4 areas: airway, sedation, skin, and nutrition. From airway, they mentioned that they recommend a wean vent to go off trach color or baseline setting if chronically ventilated, unless patient is chemically paralyzed. They recommend to use a humidifier and suction with correct techniques. And you can suction Q4 and PRN, and you should recommend head of bed elevation 30 degree to prevent VAP. In terms of sedation, it is a nightmare, but anywhere they recommend to establish SBS goal with ENT, and you need to paralyze sometimes if it is critical airways. For skincare also extremely important. We don't want our patient to have bed sores, especially around trach time. We have a team of wound care to come to help with us. For nutrition, enteral nutrition is also important, and they recommend enteral feeding algorithm. But anyways, it depends on your specific protocol in your institution. From 5 to 7, day 5, they recommend to have a first trach tube change. They recommend to use headlight, shoulder roll, flexible suction, and consider flexible scope by ENT. They recommend to assess need for cuffed, flextane, or custom trach, tracheostomy tube profile sheet with updated all information. At this time, you need to wean all sedation and continue skincare with appropriate nutrition. You have to be cautious about early complications and delay complications. I will go one by one a little bit shortly. And in terms of complications, a serious complication can happen from collective data. They mentioned that one catastrophic event every 10 years, and they report one event resulting in death or permanent disability every 20 years. But that's only information report, and if we take into account about patients, can you imagine if patients unreported? Anyways, this mentioned that more than 90% of events were reported as occurring after 1 week of trach. From early complications, a leak such as pneumo or subcutaneous emphysema, it has been reported up to 3 to 9%. Don't forget to do X-ray, especially when they transfer to our PQ. It's kind of like a routinely performed. Pneumomediastinum, they try to explain that the air dissection between the deep and superficial cervical fascia and then into the mediastinum. For pneumo, it may be secondary to violation of the pleura, especially when it approaches the trachea low in the neck. A chest drain may be necessary depending on the size of pneumothorax. Next is about hemorrhage. Preoperative hemorrhage may be prevented by meticulous attention to hemostasis throughout the procedure. Bleeding often stops spontaneously but can occasionally persist, and it's important to address it with cautery before the trach tube is placed. Most bleeding is capillary ooze, often from the thyroid gland and inferior thyroid veins, which lie anterior to the trachea must be tied if they cannot be displaced laterally. Next is about injury to surrounding tissue. Um, the cricoid cartilage and tracheal landmark need to be clearly identified before making an incision in the trachea. Injury to both esophagus and recurrent laryngeal nerve has also been reported and can be prevented by careful surgical technique. Esophageal injury is also more likely to occur if there is tube in the esophagus, with the esophagus being accidentally mistaken for the trachea. Next one is respiratory arrest. If you have a rapid washout of retained CO2, it results in cardiac arrhythmias, hypertension, and loss of ventilatory drive. From accidental decannulation, it can occur in the immediate post-op period, and the consequences may be tragic. They can calmly occur as the patient is being moved from bed to bed to travel to the ICU. The presence of stay sutures, especially in a very small infant, will help with replacing the tube through the fresh stoma. However, even if stay sutures are present, it can be exceedingly difficult to replace the tube, and there is a high risk of creating a false track. In that situation, a stable airway should be obtained by ET tube if possible. And last but not least, mucus plugging. This can be prevented by ensuring adequate humidification and meticulous tracheostomy care with routine suctioning. Constant supervision of a child with a trach tube is required to prevent plugging. Before discharge, at least two caregivers can be identified and trained proficiently in a trach care, including, you have to teach them to replace the tube in accidental decannulation. It is important to stress that trach ties should be adequately secured with no more than one finger breadth able to pass underneath them. Calm and controlled replacement of tube is essential. Hurried insertion of the tube may cause the development of a false passage with subsequent airway obstruction. How about stomal problems? This picture, I will show you granulation tissue, and this may develop secondary to friction and movement of the trach tube or chronic inflammation. Usually responds to local wound care and more frequent trach tube and dressing changes. Treatment is topical antibiotic and steroid ointment is sometimes required. Occasionally, silver nitrate cautery is required for control of granulation tissue. There are now also a number of silver-coated wound dressing on the market. In our program, we use Mepalex AG, which are very effective in treating recurrent granulation tissue. Increasing the frequency of trach tube changes from once a month to bi-monthly or even weekly can also help with stomal wound care because the tube may harbor bacteria in the form of biofilms. Scar tissue may also form around the stomas and may make tube changes difficult. In some cases, the stoma may need to be surgically revised. We also, see tracheocutaneous fistula. The incidence of this thing is very common in chronically trach-dependent children and has been reported as high as 40%. Can you imagine? Some do not consider it a complication. That's also interesting to me. How about airway? You can see suprastomal granuloma. These are very common in children with long-standing trach, and diagnosis you need a scope bedside. Depending on the extent of granuloma, treatment may be necessary. It is recommended that suprastomal granuloma be removed only immediately before decannulation unless they are significantly obstructing suprastomal airway or even bleeding or preventing passage of air for speech. And obstructing suprastomal granuloma places the child at risk if there is an accidental decannulation. In the majority of cases, granuloma can be removed endoscopically using an optical forceps or power instrument or a sphenoid punch through the stoma. Rarely, a huge obstructing granuloma may require an open approach with stomal revision to deliver and remove it. Suprastomal collapse also, you know, found, especially they mentioned that pressure on the first and second trach rings can cause local chondritis and weakening of the tracheal cartilage, causing tracheomalacia in the suprastomal region. If the collapse causes significant obstruction, it may prevent decannulation. Tracheoplasty might be considered. How about subglottic stenosis? It is the result of placement of the trach tube too high in the airway. And other factors that contribute may include trauma from prolonged intubation and low-grade inflammation often seen in uncontrolled reflux. So you need to treat reflux as well to prevent it. They also mention about A-frame deformity or localized malacia at the subglottic or upper tracheal level. Symptoms secondary to this may only become apparent after the cannulation. The next one is about tracheal or tracheitis or tracheal mucosa inflammation. They can present with intermittent hemorrhage from the trach tube. This can explain by tracheitis. It is caused by a bacterial infection of the tracheal mucosa. Frequent suctioning may be required due to increased secretions, which also can irritate tracheal mucosa and cause bleeding. The recommended treatment is with systemic antibiotics and increased humidification. It is also important that appropriate size suction catheter to correct length is used to ensure that excessive tracheal trauma is not being caused with suctioning. Intratracheal granulation tissue, often at the tip of the cannula, may cause hemoptysis or tube obstruction, and this can be removed with optical forceps or CO2 laser or even injection with intralesional steroids to help prevent recurrence. Nowadays, you can order Ciprodex, which are available on an individual basis and have shown good success. The last one, but I think the most dangerous one, is tracheoinnominate artery fistula. The patient usually presents with sudden massive tracheal hemorrhage, and this is more likely to occur in children with chronic tracheostomy dependence and is caused by the tip of the tube eroding through the anterior tracheal wall into the innominate artery. Such hemorrhage may be heralded by smaller, less significant episodes of bleeding. A CT angiogram should be performed to assess the position of innominate artery in relation to the trach tube. Pulsations may also be seen in the region of innominate artery at the tip of the trach tube on scope. Any patient who suspected of impending innominate artery rupture should receive urgent exploration by TCV. Next, I would like to show you a diagram about decannulation. So, this is from Pediatric in 2016 from North Carolina Children's Hospital. They, they have evaluation by rigid or flexible bronchoscopy to make sure that the patient are ready for decannulation. And what they done, they brought the patients into the OR and decannulate in OR and observing heart rate, respiratory rate, saturations for minimum of 1 hour. And if the patients are stable, they admit to monitor hospital in the hospital for 24 to 48 hours and then discharge with initial continuation of home nursing, pulse oximetry, and the apnea monitoring. And they have appointment in the next 6 weeks. But if they fail decannulation in the OR, they put the trach back and have a clinic evaluation in the next 6 months. Also, they have a capping trial with sleep study, downsized trach tube, and then scope evaluation in the next 6 months. And they might end up with proceed with airway surgery. That's the end of my presentation. Thank you for listening.